Okay. Tell me when you're
Uh,
ready, okay?
yeah, ready. Start. Okay.
Okay.
Good evening to all. Welcome to the YouTube channel of Gujarat Government Physiotherapy Association. Today we are going to attend a learning session with Dr. Tanvi. Let me introduce Dr. Tanvi. Dr. Tanvi Maharaja is a senior physiotherapist. She is basically from Gujarat, India. She is a doctor in physiotherapy and a US licensed physiotherapist. She is practicing at OPD clinic at Greater Boston region. She is also a certified manual therapist and she is having advanced certificate in orthopedic physical therapy. Today we are going to learn from her about adhesive capsulitis, which is a day-to-day thing for us. So I'm not taking the much time and hand overing to Dr. Tanvi. Yes, Dr. Tanvi.
Hi, Hardik. Thank you for the introduction. Today we'll be talking about adhesive capsulitis. One of the reasons I picked this topic is because it is one of the most common conditions that you will encounter in your clinical practice. The other reason is this is a condition that is more likely to be misdiagnosed, um, partially because in the early stages, it has a lot of overlap with other shoulder conditions such as rotator cuff injuries and so on. And the third reason why this condition should merits a little attention is so much new evidence has come up in the last few years regarding adhesive capsulitis that awareness of all the new research regarding frozen shoulder will help the clinicians treat their patients in a better way. At the end of this webinar, I hope you all gain some new insight, change your approach in how you see this condition, how you categorize it, and how you treat it. And I hope you all get excellent patient outcomes by following the suggestions and the clinical tips I'm about to share with you. So let's jump right into it. So your typical patient of adhesive capsulitis is probably going to be between 40 and 65 years of age. Females are more likely to have this condition than males. So you might see a 55-year-old female coming in with a painful shoulder. So that is one of the demographic criteria. The other thing that the patient might tell you is that they had a previous history of adhesive capsulitis in the contralateral arm. So my right shoulder is hurting now. The exact same thing happened to me 3 years ago in the left arm. That is kind of better now, and now this has started bothering me. One of the most important historical facts, so when you take the history of the patient, subjective evaluation, is that there is no history of any major trauma or any repetitive activities, which means that if a patient is telling you, I painted the house, or I was cleaning up the closets overhead for 3 days, 3 days ago, and then it started bothering me. So that is history of repetitive activity. History of trauma would be the dog pulled on the leash, or I lifted something very suddenly and then it started hurting me. So that is more history of trauma. In case of a frozen shoulder, both these histories are absent. So patient has either very minor trauma or no trauma at all, and there is no repetitive activity related to any household chores or any job-related tasks. The third diagnosis that you want to rule out first is recurrent shoulder dislocation, so any instabilities in the shoulder. This is again more likely in a younger patient, in a more active patient, probably people are involved in sports or doing heavy manual tasks. So in the absence of trauma, absence of repetitive activity, absence of shoulder instability or history of shoulder dislocations, 40 to 65-year female also has pain in the other, same kind of pain in the other shoulder a few years ago. This is drawing a picture of frozen shoulder for you. Risk factors, thyroid and diabetes. So when you see a patient with the presentation that we just described, your next question should be, do you have diabetes? Do you have thyroid? The reason you want to ask these questions is because it gives you an insight of what the patient outcome is going to be like. So a patient with these conditions will have a protracted course of recovery. You want to talk about this to your patient eventually at the end of your evaluation and let them know that because you also have diabetes, your outcome may be a little delayed than the normal or the average frozen shoulder. All right, so let us talk about the pathoanatomical features of the frozen shoulder. As you know, the glenohumeral joint is a synovial joint containing a synovial membrane lining the interior joint capsule, and it encases the long head of the biceps tendon, right? So into the biceps groove. So it surrounds the joint. It inserts onto the humerus, starting superior to the lesser tuberosity and the surgical and anatomic necks, and then from the coracoid and glenoid rim through the labrum and the glenoid neck. Now, the glenohumeral capsule, the coracohumeral ligament, and the glenohumeral ligaments, they comprise of these complex known as the capsulo-ligamentous complex, or the CLC. Why do we talk about the CLC? Because this is the structure that is most affected in a frozen shoulder, right? The CLC, along with the rotator cuff, creates kind of a constraining sleeve around the joint. So the rotator cuff muscles are part of the dynamic component of the sleeve, and the glenohumeral ligaments and the CLC basically is the static component. So these two restraints, the dynamic and static, work together to provide stability to your shoulder joint. So if one of them is affected, we have problems. All right. So we are going to talk about an important structure in the rotator cuff region known as the rotator cuff interval. So this is a triangular shaped tissue bridge between the anterior supraspinatus tendon edge and the upper subscapularis border. The apex is located at the biceps sulcus lateral ridge at the margin of the transverse humeral ligament. I'll show you the diagram in a second. So there it is. So you see the dotted line? That is your rotator cuff interval. You want to pay a little attention to this structure because this is the structure that is most likely to be affected in a frozen shoulder. This is where all your tightness, the frozen part of the frozen shoulder is here. This is what's frozen, okay? Primarily, there's other structures too, obviously, but this is, where a lot of fibrosis and contracture is typically going to happen. And they observed it, when they go and operate on a very stubborn frozen shoulder that is not agreeing to or not responding to your conservative management, like physical therapy or even shots, then they have to sometimes go in and operate on it and release it. And when they do that, they notice that this is the part that's very affected. So with the arm at the side, the anterior limb restricts the external rotation. So when you go into external rotation, if this is not labile or doesn't give, then you can see how it will not allow rotation of the shoulder externally. And they have also found that when they release the coracohumeral ligament, they see a dramatic increase in shoulder external rotation with the arm at the side. So that is the motion, external rotation, but with the arm at the side. So it's not out here, it's down here. Now, what are the typical patient complaints? Patient says, I cannot sleep at night. I have difficulty sleeping, wake up with sharp pain at night, or not able to get comfortable. I sleep for a little bit, wake up. So sleep disruption, pain and difficulty with grooming and dressing activities. So combing of hair, washing hair, dressing, cleaning under the opposite axilla, reaching behind the back. So end range rotations, elevation, these are difficult. Pain and difficulty with reaching activities. So reaching, forward reach, lateral reach, overhead reach, they're all limited. When we talk about sleep, I just want to, so this is not in the slides, but I think it's important to be cognizant of the fact that sleep disruption, especially sleep that wakes you up at night, in the middle of the night, sharp pain, is also one of the red flags in a variety of other systemic issues. I don't want to go into red flags now because that is a big topic. We might do a webinar at some other point on red flags, but sleep disruption, although is part of a frozen shoulder picture, is also a red flag. You want to kind of be a little aware of that. Your ears should perk up when you hear sleep disruption, sharp pain at night. Okay, so let's go on. So what are the typical physical impairment measures? So what are you measuring? What are you checking? Okay, so your examination should contain a pain scale. You can use the VAS or NPRS. VAS is visual, so you show them a strip 0 to 10 centimeters and they mark a circle, and NPRS is more like a verbal. Okay, on a scale of 0 to 10, how bad is your pain? And then I usually take average, best, and worst. So you have your average pain, so right now, and best pain number at rest, worst pain number when you do the things that bother you, how bad does it get? So you want a scale and an average number. And of course, you will take active and passive range of motion measurements. You'll use your manual techniques, your manual palpation exam to see how much translation is possible, how much accessory motion is possible here in this joint, and you assess for end feel. So of course, the active and the passive range of motion measurements, the difference between them, or seeing how much of a variation you have in active versus passive, will give you an idea of whether it's a cuff involvement. So pain only with active but not with passive is more muscular, more active tissue, and the pain at passive or restriction at passive is more inert tissue. So active and passive are both limited. You're thinking more inert tissue like ligaments or joint capsule. Pain only with active, more muscle. So every time you see a patient, you want to take a patient-reported outcome measure. So when you take the exam, this is your perspective, but you also want the patient's perspective because this is a teamwork, right? You can't just say, okay, I think this is what you have. You also want to know what the patient thinks, how much they are limited. The shoulder has a few outcome measures that you can use for frozen shoulder. These are the different outcome measures. The one I most commonly use is the quick dash. So it's a questionnaire which asks you about how much limited do you feel doing daily tasks. And then it is, I think, 11 questions. And you rate them from 0 to 5. And then if you go on the link that I've given here, the PDF gives you how to score it. So say a patient has, when you get the score, it converts it into a percentage. So you know how much limited the person is. So if they have a score of 75% when they first saw you, and then at the end of the month, you give them that questionnaire again, and you see the score again. And if they have gone down to 25%, that is a good sign. So the quick dash is a measure of disability. So a measure of disability, higher scores are bad and lower scores are good. So you want to see the score go down. With a functional scale like the ACEs, a higher score is better. So if you want to start at 30, you want to go up to say 70, 80, right? So once you see these questionnaires, you get an idea of how they work. But these are good ones to hand out to your patients. All right. Now, range of motion finding. So you take those range of motion measurements. What is the one thing you're looking for with frozen shoulder? You're looking for passive external rotation range of motion with the arm at the side. Again, arm at the side, and you want to see how much they're able to externally rotate their shoulder. If the range of motion passive is less than 30 degrees or less than 50% of the opposite side, this is a hallmark sign of frozen shoulder. in almost no other shoulder condition will you find this presentation. Okay. Some of the other things that you'll also find is that as you go from 45 to 90 degrees, the external rotation decreases. So say here it's only 20 degrees. As you go up a little, you get a little more range. So you may get, like, say, at 45 degrees, you may get 50 degrees. But as you go up to 90-degree abduction, that goes back down to, say, 40 degrees or 30 degrees. So that gives you a clue, directs you more towards the diagnosis of frozen shoulder. Same happens with internal rotation range of motion. End range, passive range of motion is painful. So for elevation, for internal and external rotation, so elevation is flexion, sagittal plane, frontal plane abduction, and rotation end ranges are painful. You'll also find limited ranges with your manual palpation. So joint glides, accessory motion, you don't get as much gliding in the joint. It's stuck, it's frozen. Okay, so I want you to remember this. Here, external rotation range of motion with the shoulder adducted is limited, less than 30 degrees. So I know that many of us, including me, we learned the C-reaxis model of how external rotation is more limited in abduction, more limited than internal rotation. That has not been found to be consistently true in all patients with frozen shoulder. Okay, so although a lot of us still practice that, that is not what new research and new evidence suggests. Loss of passive ER with the arm at the sign, hallmark sign of frozen shoulder. Always, always look for that. You should not miss this one. All right, now comes another important criterion-based examination. You want to determine a patient's level of irritability. So how much, how are your patients responding to any kind of movements? So irritability is a term used by rehabilitation practitioners to reflect the tissue's ability to handle physical stress, and it's related to the physical status and extent of inflammatory activity that is present. So how much inflammation is present inside is reflected in how much they are able to move and use their arm. So high irritability, even moving their arm a little causes a lot of pain. Moderate, they can move a little, but it's still painful. Low, they can do a lot, it's not as painful. Each irritability level has certain signs and certain criteria that we'll discuss now. So high irritability, level of pain on NPRS more than 7 on 10, so 7, 8, 9, very high pain. Consistent night or resting pain, hurts every single night. It's not like once or 2 times a week. Every single night they have pain. When you give them that quick dash score, they are off the charts, 80%, 90% disability. Pain occurs before you even reach that end range active or passive movement. So very painful from the get-go. And AROM and PROM measures have a vast difference. Okay. So passive, say passive flexion might be 120 degrees, but if you ask them to do that actively, it's significantly less. Moderate pain is 4 to 6. So it's painful, but I can live. Intermittent night or resting pain, 3-4 times a week. Usually hurts only when I move it, not much resting pain. Moderate level of disability on your quick dash, and pain is mostly at end ranges of active and passive movements. It's only when they reach that end range extension or end range external rotation or end range internal rotation. And active and passive are almost similar. Low irritability, again low, less than 3 on 10, no night or resting pain, minimum quick dash scores. Pain is only with overpressure into the end range of passive movements, and active and passive range of motion are almost similar. All right. So that is the level of irritability. That is for you as a clinician to know how much you can push this patient. The level of irritability coincides pretty well with the staging of frozen shoulder. So you know that adhesive capsulitis is a protracted condition. It's not something that will go away in 2 weeks or 2 months or 3 months, like your rotator cuff or shoulder impingement cases, right? These patients usually get better in about 3 months or so. Not so with frozen shoulder. It is a staged progression of pain and mobility deficits. It can last anywhere from 12 to 18 months. And even beyond that, mild to moderate deficits may persist, but those are very minimal and don't usually cause significant disruption to patients' daily activities. So you want to explain this to the patient, right? You want to tell them from the get-go that, all right, just want you to know that this condition lasts a long time, from 12 to 18 months. That does not mean that you will be in so much pain for 12 to 18 months. As soon as you progress, it has so many stages. As soon as you cross stage 1 and 2, things become a lot better. Although your range will not be full, you will have less pain, less symptoms, which means that you'll be able to do more without going through so much pain. This gives the patient hopes. It sets their expectations, so they're not asking you after 3 visits, why do I still have pain? You want to set their expectations. You want to let them know that this is a condition that takes time. It's important to talk to them at their first visit. So not only are you being transparent and honest with your patient, but you're buying them trust and you're setting them up psychologically to deal with this. Okay, it's a good skill to provide to your patient, education. All right. Because people, patients tend to get fixated on range of motion. It's still, what, how much? Like you take a measurement and, oh, it's still 110. Why am I not getting it up? So you're like, okay, it's still 110, but it is your 3rd month. Is your pain any less? Yeah, pain is less. Are you able to do more? Your quick dash scores are better. So you are getting better, although the range is still the same. So don't let them get fixated on range of motion measurements. And the best way is to talk to them on day 1. So this is the chart that you want to show to your patients as they go from that initial phase, freezing, frozen, thawing. There's 4 stages. Actually, this one has only 3, but there's 4 stages. The first is the inflammatory stage. But as you can see, as time goes on, the pain lessens, the movement increases. So you have a happy patient. All right, so let's talk about the stages. The inflammatory or the painful stage, about 3 months, sharp pain at end ranges of motion, achy pain at rest, sleep disturbance, right? So the first and the second stages are the most disruptive in a patient's life. Once they get over that, it's not too bad. You typically see the patient at the end of the first stage. So they've been dealing with this for, quite a month or 2, and it's not getting better. And then they saw their doctor and they're referred to you for therapy. So when I see patients, it's usually at the end of this first stage. So I tell them that you crossed, almost 50% of that painful part. So it's just a little more left to go, which is stage 2, which is the painful or the freezing phase. So in the first phase, it was more pain, not so much movement loss. In the second phase, which is probably the worst phase, you have pain and motion loss, both happening together. And this can last anywhere from 3 to 9 months. And the pain is related to the aggressive synovitis and the angiogenesis. So new blood vessels growing into the shoulder, as part of the inflammatory process is what causes that. I just wanted to talk to you about this a little more. So in the first stage, when they did arthroscopic exam, they found that there was a diffuse synovial reaction without as much contracture, which is why it's more pain and less motion loss. In frozen shoulder, what happens is that initial inflammation, the stage 1, not only do they have inflammation, but they also have more focal vascularity. So there's angiogenesis, growth of blood vessels, And along with the growth of the blood vessels, there's also new nerve growth in the capsulo-ligamentous complex, or CLC. So this nerve growth is what explains that heightened pain response in the first stage, which is why it's so painful, right? So inflammation, new blood vessels, and new nerves growing into that shoulder complex is what gives them so much pain in the initial stages. All right, now we go to stage 3. So frozen stage, little pain, more moment loss, lasts from 9 to 15 months. You'll probably not see the patient at this point. Patient is probably on a home exercise program, doing their exercises at home consistently. When they do an arthroscopic exam at this point, they find a lot of capsulo-ligamentous fibrosis, a lot of thickening, tightening, and that loss is usually more in the axillary fold down here, which is why they cannot go up. Elevation is restricted. So when they test under anesthesia, the motion is still restricted. So it's not related to any muscle inhibition or pain response, right? So when you're under anesthesia and you still have a motion loss, you know that it's mostly inert structures, tight structures. It's not related to pain. All right. So after about that 12 to 15 month mark, your patient crosses into the stage 4. Patients are the happiest in this stage. The shoulder is thawing. They start to see their motion coming back. I can finally reach behind my back. I can wash my hair without a problem. I can reach up all the way into that topmost shelf. So you have a really happy patient, which you will unfortunately not see because they don't want to come to your clinic anymore. They're doing great. Some motion restriction may persist, so maybe that very end range, but it's not painful at all. The synovial involvement is receding, the fibrosis is still there, but not as much. In some patients, especially if you have like diabetes, they do see symptoms a little longer, but again, nothing as bad as when they first came in that inflammatory or freezing stage. Happy, happy stage. Thawing, everything is thawing and moving, nice and smooth. All right. So a lot of times when you discuss with your patients that this is a self-limiting condition, right? You tell them these are the 4 stages, it can last for 12 to 15 months, and then it gets better by itself. The first question your patient will ask you, if it's going to get better anyway, why do I need therapy? Why do I need to come see you? What is your role? How can you help me? It's going to get better anyway, right? Like you said, why should I come see you? All right, so first of all, you want to tell them that based on your irritability levels, I can design an exercise program for you that will keep other muscles in good shape, right? So when you have a shoulder that's not moving, you have a lot of muscles that are not working. So you want to keep those muscles in good shape. You want to make sure that a patient with frozen shoulder doesn't start moving abnormally and end up having impingement on the other side or impingement later on the same side when the thawing begins. So everything is thawing and moving after a year, but because they didn't work their muscles, didn't move their scapula properly, now they have other problems related to the rotator cuff and things like that. So you can tell them your job is to avoid long-term complications that can happen later on. And you can tell them, you know that this is going to get better because I'm telling you this. So that is one of my jobs, education. I explain to you what this looks like, how it progresses, and based on each stage, we can modify your exercise plans. Okay, so that's your role. All right, so how do you treat a patient? You treat them based on their irritability. Again, coincides more or less with the stages, but then again, every now and then you'll find a patient who is in the frozen stage, but still has high irritability. Some patients just have a higher pain response. So patients with high irritability, you want to start with heat for pain modulation, electrical stimulation, so IFT, TENS, You put them on a self-care home management exercise program, which we'll talk about later at the end. This is just to give an idea of how you will treat a patient with high irritability differently from one with moderate or low irritability. You have a different approach towards each patient. Okay. So patient education on activity modification and comfort. You cannot still be playing tennis. You cannot still be, cleaning everything like you used to. You had to tone things down. You have to modify what you're doing. You want to limit the inflammation. You don't want to irritate your shoulder anymore. So you can continue doing things that you are doing right now, but with a lot less intensity. You want to really tone it down. Manual therapy. So low intensity joint mobs, grade 1, grade 2 maybe at most, no more than that. Very low intensity, only for pain modulation. And in the pain-free region. So you don't want to go up here and do any mobilizations. You want to stay down and low in the ranges that don't provoke their pain. Mobility exercises, active assisted exercises, pain-free passive range of motion exercises, very useful. You want to keep things moving as best as they can, and active assisted when patients are ready for it. With moderate irritability, you can still use heat and electrical stimulation, but you might not need so much of it, maybe for the first few sessions. Again, patient education on modification of exercises depending on their symptom response. So see how your shoulder behaves, do a little bit, try it. If it hurts, stop. If it hurts, reduce the intensity or the frequency or the duration of your exercises. You want to modify those things. When you progress joint mobilization, you want to increase the amplitude and duration of procedures into tissue resistance without producing post-treatment tissue inflammation and associated pain. So only go so much, and you don't want to be very aggressive with your joint mobs. Easy does it. You can do like a grade 2, grade 3 here with this moderate intensity patients. Stretching exercises, we'll talk about that later, and we'll talk about what criteria to use to decide how much stretching this patient can tolerate. Gentle to moderate stretching. And then you have neuromuscular re-education, scapulohumeral complex. We'll talk about that too later on. And low irritability, don't want to use any, waste your time on any modalities, no heat, no TENS, no IFT. They don't need any of that. Okay, you can go right into patient education, encourage them to use the shoulder as much as is possible for them. So don't tell them, oh, you need to take rest, you need to limit it. No, these are the patients you want to encourage to move. If they are fearful of movement, you want to give them the confidence to be able to use their shoulder again. Okay. The joint mobs, you can go into some end range mobilization now. You can do high amplitude, long duration procedures into tissue resistance. You can push a little more, go up to grade 4 and beyond. No problems here. Again, low irritability you'll probably see later. You'll probably see them into that frozen stage if they show up to you at your clinic in this stage. Sometimes in the freezing stage too, you'll see a low irritability patient. I've seen a couple of patients just 6 months down the line, so still, just towards the end of their freezing stage, and they're doing fine. They're very low irritability, and we were able to do a lot more. So these patients probably got better close to that 12 to 18 months, so close to the 12 month rather than the 18 months. With the stretching exercises, again, you can progress the duration of stretch into tissue resistance as long as you're not causing any post-treatment pain. And neuromuscular re-education to integrate gains in mobility into normal scapulohumeral movement during performance of activities that they do in their function or recreational activities. So if you have a tennis player, you want to show them exercises that will take their arm into abduction and external rotation. and then teach them scapular control and movement to be able to do that more efficiently. Right? Similarly, if you have a swimmer, you want to modify how you're doing their X. You don't want to give them a cookie cutter exercise and give the same exercise to all your frozen shoulder patients. You need to customize it. That's where your skill as a therapist comes in. All right. So the outline of physical therapy treatments. First and foremost, patient education. Set expectations, talk about what activities they can or cannot do, and how to know how much they can do. As far as exercises are concerned, stretching exercises have the highest evidence, and research suggests that they help more than AROM exercises or joint mobilization. So manual is well and good, but stretching does the trick. See that CSI at the end? That is your corticosteroid injection. Especially if you see a patient in that first couple stages, stage 1, stage 2. CSI and physical therapy make a very good marriage, right? So you want to talk to the patient about possibly getting a CSI, or if you know their doctor, you can call them up and say, hey, I think they'll do great if they have a corticosteroid injection. It really helps the patient get over that intense pain and participate more in their exercises. So if you have a good professional working relationship with the MDs that refer patients to you, definitely talk to them about, if they haven't already, talk to their patient about getting that CSI. Patients will love you for it because you save them unnecessary pain and discomfort and really speeded up that recovery process. So tell your patients it doesn't have to be CSI or therapy. It can be both. It should be both if the patient fits that criteria. And then home exercises and modalities are moderate evidence, not so strong evidence, weak to moderate. Home exercise programs, so you have to maybe give them a printout sheet of exercise of what to do and tell them to be consistent, maybe make a little checklist of what they've done each day. And modalities, we'll talk about that in a minute, what works, what doesn't work, but not the best evidence for that. So don't waste your time on things that don't work. Okay, let's talk a little bit about active assisted range of motion exercises. So you see each of these diagrams over here. So any active assisted range of motion exercise can also become a stretching exercise if you just hold that end range position for a little while, right? So these are the standard exercise. If you Google frozen shoulder exercises, you'll see a lot of pictures like this coming up. So I'm sure you're all familiar with all of this. Nothing new to see here really. Same old exercises. You want to cover all planes of motion, and you want to decide how much to hold based on patient irritability. Right, so table slides, flexion. You can also do sideways abduction or into external rotation. This is a better way of stretching that I like versus table slides, because patient is able to control that more actively, but again, not great for someone who has balance impairments. So see what will work good for your patients. All right, so let's talk about how much to stretch. Not every person will stretch the same amount, the same duration. So for stretch exercises, there is a phenomenon called TERT, which is the total end range time. So how long is your patient holding that end range position in total? So let me give you an example. So again, TERT is frequency multiplied by duration. So how often do they do that? That's your frequency, and how long they hold it as your duration. If you have a patient with high irritability and you want to say, have them stretch for a total of 1 minute before starting their exercises, which is very less, but I'm just going to use 1 minute as an example here. You want a patient to stretch for 60 seconds, but they're very irritable. You want to ask them to do 5-second holds and do that about 12 times. That will get you a total stretch of 60 seconds without aggravating a patient who is in that high irritability stage, not stage, but phase. If you have a patient who is moderate irritability, they can hold a stretch for about like 15 seconds. Then you want them to do it 4 times to get your 60 seconds. If they can hold it for 10 seconds, have them do it 6 times. So do your math, but get that 60 second in all. So if you have them do 10 seconds and do it just 3 times, you're not stretching it as much as you should. Your low irritability patient will be able to hold a good 30 seconds, in which case you do it twice, okay? So that is ideally your goal, to get them to be able to hold to 30 seconds, but not all patients will be able to do that right away. If you see patients in the initial stages, they'll be highly irritable and you'll have to start at 5 seconds, have them do it frequently, okay? A low load stretch, which is prolonged, is the LLPS, a low load prolonged stretch, maximizes the total end range time and induces that tensile stress that you need to bring about that change in tissue structure to make the tissue more pliable. Remember how we talked about all that fibrosis and contracture? So you need to apply a low load prolonged stretch, which means you don't have to be super aggressive. You don't have to be pushing like crazy or doing those very hard doorway stretches. The patients don't need that. Nice and easy does it with frozen shoulder. Just make it prolonged. You want to get to that 30 seconds. You don't want to be super aggressive. You don't want to push things. If you have a little pain, very little pain, so 2 or 3 on 10 while you're holding the stretch and the pain goes right away, there's no more pain as soon as you let go, that is the right amount of stretch. If you stretch at pain levels of 8 on 10, 9 on 10, like you're dying, you're sweating while you're stretching, and then your shoulder hurts for 1 hour after you stop stretching, buddy, you did too much. That is too much. Not ideal for frozen shoulders. You're just increasing that inflammation inside. You're going to make the fibrosis worse. Remember all those new blood vessels, all the new nerves growing along with those blood vessels, just increasing the pain response, increasing the fibrosis, not good for your patient. So tell them, take it easy, hold longer, but don't hold too harsh, okay? So this is very important because I know people will like, stretch. No, please don't. Okay. When you talk about active assisted end range stretch, we're thinking butterfly stretches, and as the irritability lowers, so this is your butterfly stretch, and as they get better, you can start going into the sleeper stretch. This is a very, very intense stretch. I would not advocate doing that initially. Give your patient some time, okay? Give them some time with your butterfly stretches. So they stretch the posterior elements of the capsule, stretch the interior elements of the capsule, nice and controlled, start in supine, progress to sitting, and then finally, as they're able to hold for 30 seconds at end ranges, no pain, try a sleeper stretch, start at 5-10 seconds for about 12 or 6 times, depending on how much you're holding. Keep that TERT in mind, then progress gradually to 15, 20, eventually 30 seconds. Don't start on a sleeper stretch right away. Day 1, patient seeing you, frozen shoulder, let's do a sleeper stretch. Bad idea. Please don't. Joint mobilizations, scapular mobs. So we all are familiar with scapular mobilizations. My favorite way to do a scapular mob is in side lying. You take your arm under the patient's axilla, put the top arm on the supraspinous fossa region, and guide them gently, elevation, depression, protraction, retraction, get them nice and moving, nice and smooth. Side lying, your muscles are relaxed. There's no gravity working, gravity-free range. Get them moving, get that muscle inhibition to calm down, and the pain response to lessen. Your scapula moves better. the patient is going to be in a better capacity to perform all your neuromuscular re-education exercises afterwards. Okay, scapular mobilizations. Whatever you do it is fine. Side lying is the way I do it. Joint mobilizations. So do yourself a favor and check out this JOSPT paper. It's free access. You can all have a look at it. That I put here in the reference. The joint mobilizations, I know we all studied the arthrokinematic rules of concave, convex, you know, how one moves on the other. And you must have learned in PT school that to increase external rotation, you have to do anterior mobs. This paper found out that posterior mobilizations work better to increase external rotation range of motion than anterior mobs. So posterior glide, you want to start at end range of abduction in ER. So you want to start posterior mobilizations in this range and then lower and come down to a fully adducted position as the patient gets better. My favorite way of doing posterior mobilization is in 30-degree scapular plane and going in a posterolateral direction. So you don't want to go straight posterior like this, because then it's just going to grind against that glenoid rim at the end. You want to go in this range. Okay, so it actually has space to move. If you go straight like this, you're hitting the glenoid rim. You're not getting any mobilizations. Posterolateral mobs to increase external rotation. That's what new evidence suggests. So the picture here shows anterior mobilizations. Because when you do a Google search to find mobilizations to increase external rotation range of motion, this is what shows up. You can, of course, do all kinds of mobilizations. I'm not saying that only do posterior mobs. Depending on what you find with the patient, you can also do anterior mobilizations and inferior glides. They're all well and good. But this is a nice paper to get some new insights. Scapular mobility exercises. You want to do all 4-way scapular mobs. You want to do isometric holds at each range. You want to do rolls. You want to do clocks. So clock is hold at 12 o'clock. Then you hold at, 3 o'clock, 6 o'clock, 9 o'clock. You can do that sitting up. Later you can do lying down. You can also start doing some arm motions. You can have them go up a little and then do all those 4. You can have them go out into external rotation and then have them do those scapular clocks. So different ways of doing it. Put a band in their hands, put a dumbbell, get them in a closed chain position. So many ways to do scapular exercises. Get them going into scapular exercises so they don't end up with long-term complications like we talked earlier. Yeah, just one more thing. With this scapular exercise, I do like the retraction with depression hold. So you retract, then you depress the scapular blades and you hold that. So that's a nice partial hold exercise for all patients. All right, now scapular stabilization exercises as described by Job in his landmark paper, which is here in the description. So he had a series of exercises that he prescribed. What the patient is doing here in this diagram is shoulder extension with scapular retraction. Then you have your T's. Make sure your thumbs are facing up to the ceiling when the patient is lying prone, doing the T's. And then you have the Y's. So the arm is more up, higher in abduction. So this patient has his arm in about 95 degrees abduction. I would like the arm up higher at about 140 degrees abduction. So not your ideal Y, but this is a good modification of your standard Y in a prone position. Patient is on a physio ball using a lot of core muscles. I would have the patient tuck his chin down a little more to minimize that neck extension. That neck is going up into a little more extension here. All but those are your Job's exercises. Okay. And then you have the side lying ER. So you can begin with side lying external rotation and then have them go up into 90-degree abduction with external rotation in prone. Patient will have a hard time with the side lying because they don't have the range, but you still got to keep those external rotation, the posterior cuff muscles working. So they still need to do this exercise, even if they cannot go into external rotation, right? Because we know that they won't have more than 30 degrees to begin with. But if they start from an internally rotated position and go up into as much external rotation as their shoulder allows them, they are still working the muscle, they're still benefiting from the exercise. So tell that to the patient. I know you feel like you can get there, but even if you lift so much, you're still working the muscle and that's good for you. So you need to keep doing this. Closed chain. Closed chain exercises are my favorite kind of exercises because, well, they are my favorite exercises for so many reasons. Let's not get into the reasons. Let's just talk about the exercises. Push-up plus. So push-up with pronounced protraction at the end of the push-up. Ball wall stabilization. Patient puts his hand on the wall. You can use a ball if you want. So ball is on the wall, hand is on the ball. Patient pushes the ball into protraction, and then the patient can either do circles or letters on the wall, or the patient holds the ball against the wall with his shoulder protracted, and you move the ball in different directions, and the patient has to stabilize it against your movements. So that's a cool exercise to do with them. Patients love it. Quadruped exercises. So patients in a quadruped, they can do a push-up plus, they can do a push-up plus and a T on the other side or a row on the other side. Or they can do a quadruped exercise and then move their lower limbs into extension, or they can do chin tucks with quadruped, push-up plus. So many variations possible in the quadruped. Prone on elbow exercises, again, prone on elbow with protraction. They can do prone on elbow and then slide up and down to get that shoulder going into elevation and depression. Great exercises. If a patient is able to do them, these are tough exercises. And then you progress all these exercises onto more unstable surfaces. So we're talking a physio ball or a BOSU or a foam, something unstable, and that provides more challenge to the patient to work the scapular exercises and get nice stability in the scapular region. Thoracic mobility, very important. End range elevation has contribution from your thoracic spine. So if your thoracic spine does not have good extension mobility, you will be limited in extension. So we know that patients with frozen shoulder already have limitation in elevation. And if you have thoracic mobility, that just makes it worse. So getting even a little more mobility in the thoracic spine, you'll see a change in how further up they can go. Foam roll thoracic extensions or thoracic extension on chair. You can do a manual thoracic extension thrust, screw manip. So many things you can do for thoracic mobility. So that's one. And then I would also do some rotational mobility. So transverse plane thoracic mobility. If you notice one side is less than the other or both are limited, or just to get them moving a little better, get nice extensibility. So here the patient is doing a side lying open book exercise. You can also do a quadruped rotation. There's a lot of variations on this. So definitely address the thoracic spine. Okay, very important for shoulder mobility. So when I studied for my OCS, I learned a lot of different techniques. I'm also a manual therapist. So I picked up some techniques there. So there are specific exercises and stretches that you do for the rotator cuff interval or to just kind of get better mobility in the posterior superior CLC. These are beyond the scope of this webinar here, but if we ever happen to come together and maybe do a workshop or something when I come to India, we can definitely go over these, some cool techniques there. All right, let's talk about modalities. The only modality I personally use for frozen shoulder is a hot pack. You do a hot pack while the patient stretches, the patient comes to your clinic, you put a hot pack on them, and then start doing a little extension, external rotation, mobility. So give them a cane, they start doing a little like ER, hot packs on their shoulder, they just hold that ER for 30 seconds, relax 10 seconds, go out again 30 seconds. The hot packs on them provides a little pain inhibition, and you'll definitely see a change. So only modality that I use is a hot pack for frozen shoulder. There is some evidence, which is very weak again, for shortwave diathermy, for TENS, for IFT. I don't use any of those because I find that my time is better invested in doing manual work and exercise with the patient. If you want to use them, that's fine. There is evidence against the use of ultrasound, massage, and anaphoresis and phonophoresis. So I would definitely not advise using any of those, okay? Sometimes the patients are, oh, ultrasound helped for this, and maybe it will help for frozen shoulder. You have to tell them that evidence suggests that using ultrasound gives no benefit, and it's a waste of time. If you still want me to do it, I'll do a little bit, but maybe just for this session, we'll not do it anymore. I put my foot down on that one because your job is to provide good treatment to your patient, evidence-based, right? CSI, excellent adjunct to therapy, especially in the early stages when the pain levels are high. We talked about this, talk to the AMD, and you'll see a dramatic change. Corticosteroid injections for frozen shoulder, a big yes, resounding yes, several studies to back that up. All right, let's talk about some clinical tips. So little tricks that I use with my patients, okay? So first of all, I always take a pre and post-treat measure, okay? So patient comes in, I put the hot pack on, have them do that little stretching 30-second hold, do it for about 5-10 minutes, 30-second hold, 10-second off, 30-second hold, 10-second off, hot pack is on them. I've taken the measurement as soon as they come in, I have them do this, and then I take a measurement again. Usually you find a 10 to 15 degrees difference because the pain has lessened, the muscles have relaxed, they are not contracting or inhibiting those motions. So you will see a big change, a big boost for the patient to be home exercise compliant. So keep doing their home exercises. So if you show them that your shoulder is getting better, they are more likely to have that buy-in and will trust you for the exercise program and for anything that you tell them for that matter. So cold measurements and then repeat post-test. When you do the pulleys with patient, if you have a pulley at your clinic and you're having them do pulleys, you want them to start with the shoulder in forward flexion and with the elbows extended. If they are here, then they've used that external rotation already. So when they go up, they don't have any more rotation there, and then they will not be able to go up any further. If you start them out here, they're starting with a little internal rotation. So as they go up, they're allowing the external rotation to happen, and they get a little more movement in flexion. So always start with your elbows extension when you're having them do pulleys. Pre-treatment heat application has to be done with the arm in 40 degrees of scapular plane abduction, not frontal plane, scapular plane. Scapular plane abduction, about 40 degrees. Keep the arm rested, put up a few pillows here. Keep the arm rested in as much external rotation as is possible. So you have a lot of pillows here and under your arm, and then you put a heat pack. Put a cane in their hands, 30 seconds, 10 seconds, 30 seconds, 10 seconds. Do it for 5 minutes. All right. Oh, it says 20 seconds here, but yeah, you can go up to 30 seconds depending on the irritability levels. So high and moderate irritability level patients will show a greater change in cold measurements versus post-treat measurements because their muscles are, kind of relaxing more, and the pain is going down more. So you'll see a bigger change in those patients. Patients already very low, have low irritability, you will not see a big change, which is fine because they don't care anyway. Okay. So passive range of motions. After you've done that warm up, you do some passive range of motion with the patient. Then you have them go and do the pulleys. Then you do some joint moves and gentle manual stretching. So you do a lot of work with the patient, and then you have them do some active range of motion and scapular exercises. So pulleys, depending on where the patient is. If it's the first few sessions, I have them do it in the beginning under my watch, in between, my personal care. And then once they are used to the pulleys and they know how to position their hands, then it's part of their thorax. Joint mobilizations initially in the loose back position. You can do anterior, inferior, posterior glides. Like we said, posterior glides work better for external rotation range. So if that is your goal, to increase ER, posterior glides is the way to go. And ideally it's posterolateral glides. So again, not posterior, posterolateral. Traction and rotation oscillations may also be performed intermittently between translation glides. So you do a little posterolateral, then you give them a little traction and a little oscillation, and then more posterolateral. Again, a little traction, some oscillations, and then you can switch around and do some inferior glides or anterior glides, depending on the patient's limitations and what you're hoping to achieve with that. Now, it is your responsibility ethically to refer the patient back to their MD if they're worsening. Do not keep the patient coming to your clinic if you can see that in 3-4 sessions they're just getting worse and worse and worse, even if you have modified how much you or they are doing. Okay, because a timely shot, a timely manipulation under anesthesia can work wonders for the patients. You don't want to put them through misery if they're not benefiting from exercise. The patient comes in for the first 2 visits, the pain is getting worse, you try to modify things, you backed off from aggressive manual, you didn't stretch too much, you ask them to take it easy at home, your exercise program is very light, and they're still getting worse, there's more pain, more mobility deficits, refer them back to the patient. Do not keep them in your clinic. They need a shot. Sometimes things have progressed really bad. Some patients just tend to have more inflammation and they need the shot, or they might need to be manipulated, sometimes even surgery to release the structures. CLC remodeling does take time, so which is why we take 12 to 18 months to get over frozen shoulder. So be patient if irritability is low to medium. So if the patient is like, oh, why is this taking so much time? You want to explain to them it takes time. That's just the nature of the beast. There's nothing you or I can do about it. It's just how the tissues work. Just be patient, keep doing your exercises. When the patient reaches that stage when the irritability levels are very low, I like to have them do more at home. So I only see them maybe once every 3 or 4 weeks, just kind of touch base with them and progress their exercises and make sure everything is going as planned. I don't need to see this patient twice a week anymore. Okay. All right, let's go on to what I think is our final slide. As the patient progresses, you want to progress to joint mobilizations in the end range, because now they are low irritability. You can go to end range positions and do your joint moves. You want to include some PNF patterns like hold, relax at those end ranges to kind of loosen up the muscles a little more, reduce that inhibition and get more range in those end ranges. You can add mobilization with movements. So you're giving a posterolateral glide and the patient is doing an external rotation, or you're doing inferior glides as the patient is going up in elevation. Great exercises, great manual techniques as the patient gets better and better. And then, of course, there are advanced rotator cuff interval stretches that is not within the scope of this webinar. But if you know them, go ahead and do those. These are the references I used for the most part today. And You just want to know that frozen shoulder is a very complex condition. There are many pieces, to this puzzle. You want to make sure you get it right, you get the full picture, you explain that to the patient, have that buy-in, buy your patient's trust and confidence, because if your patient trusts you, they will listen to you. If they listen to you, they're more likely to get better. Okay. It was very nice presenting this webinar to all of you today. If you have any questions, please feel free to put them down here, and we'll get talking sometime in the future. Thank you for your time, and have a good day, everyone.
Yeah. Hello, Dr. Tanvi. It was very good. It was very good. It was covering almost all the aspects, and it was quick revision for me also as a clinical therapist. And one thing that you have explained very well, that pain and function is important rather than range of motions in case of adhesive capsulitis. Most of the students or clinical therapists focus on the range of motion. Whenever the first thing comes in our mind uh, is range of motion when we think about adhesive capsulitis. And almost you have covered all the questions which we have covered, but few things we want to discuss with you. First thing is regarding ergonomics. Ergonomics in case of adhesive capsulitis or computer work or sleep habits. Patients many times ask, okay, I couldn't sleep, which is the best or comfortable position that I could complete my sleep.
Right. So ergonomically, when a patient is sleeping with their hand, hi, can you hear me, Hardik?
Yeah.
So when a patient sleeps in too much internal rotation, they are putting a lot of stretch on their rotator cuff muscles. So an ideal sleeping position would be with a pillow under their arm. So that's ideal. You want to avoid sleeping on the painful side. So at least you can tell the patient, at least start by not sleeping on your side. If in your sleep you turn around and go on your side, your body will tell you that it's bothering them and you'll turn over, but don't start off in that position. Ergonomically, when you're working on a computer, you always want your elbows and your forearms rested. So you don't want to sit with your elbow hanging down, because that puts a lot of stress on the shoulder. And I tell them the best posture is your next posture. So there's no such thing as an ideal posture. You don't want to be in one position for too long. Any posture that keeps you in a fixed position for too long is not good for you. Keep moving. Every 20-25 minutes, keep it moving.
Okay. And any typical advice for Indian housewives, that situation?
Yes, especially I know that situation.
Especially when dominant hand is involved.
Yes. So share your workload. Have your spouse involved. That is my number one exercise tip for them. Right? Get support of your family. The second is try and use the other arm more. Use both arms. If you want to lift something heavy, use both hands. If you are in the habit of doing something with one hand, try not to do it for a prolonged time. So give yourself a break, do one activity, then find something which involves a different muscle group. So if you're doing a lot of elevation work, you want to take a rest after a while and do something which is under waist level. So mix up your work schedule. Don't do one thing for, continuous. Repetition is not good for you.
Okay. And Dr. Tanvi, we talk about heat only. Is there any role of ice according to your experience, or should we advise for ice for any case?
For frozen shoulder, heat is the better option. Ice can be used later in the low irritability or in the thawing stage if the patient has muscle soreness from exercising. So ice works better for muscle soreness than for frozen shoulder itself.
It may be role of climate also. In India, we have a very hot climate, so people love to do icing.
They love to ice, yes. So, I honestly think that heat or ice just changes the tissue homeostasis. So whatever temperature the tissue is at, if you apply heat or ice, you're changing tissue temperature, thereby encouraging increased vascularity. So at the end of the day, whatever works for you, you do that. If you're changing the temperature of the surrounding tissue in relation to the tissue affected, you're making things work. So whatever works best for you.
Okay. And Dr. Tanvi, you talk about shoulder stability exercise, right? So what is the ideal time to start with? At the end of rehabilitation or in between we can start, or depends on the patient's concern?
No, from the get-go. Shoulder stability exercises, if you're doing like isometric holds in sideline position, you're doing four-way isometrics, start them on day one.
Okay, yeah, that will be a good thing if we start early.
Yep, yep.
Like,
The earlier the better. Absolutely.
it was a very nice discussion and great learning with you. And definitely, we are looking to learn from you advanced OMPT techniques whenever you come
Sure,
to
sure.
India.
Definitely.
Definitely, we will arrange something. And uh, once again, thank you so much for your time and your detailed learning. It was very quick revision, also some new learning for me also. Definitely, it will be very useful for the all the students and the clinical therapists. Thank you so
My
much,
pleasure.
Dr.
It was
Tanvi,
great.
for your
Thank
time.
you. Thanks, Hardik. Bye-bye.
Yeah, yeah, yeah. Bye, goodbye.
Bye. Goodbye.